Thank you so much, Nico. I appreciate this opportunity to share with you our experience in creating a measurement tool, the Health Opportunity and Equity Initiative. We see it as more than a measurement tool, but also a way of harnessing action, much in the same way that County Health Rankings does. So I was very pleased to hear Marjorie commenting on the wonderful work that they've done. We're also, of course, inspired by America's Health Rankings, many other important equity measures, but I also want to acknowledge that we had a wonderful National Advisory Committee that wrestled with many of the same issues that you all are wrestling with, Tom Eckstein being one, so very grateful to Tom for his assistance. That committee was chaired by David Williams at the Harvard School of Public Health and a number of other outstanding experts. So HOPE became what it is because of advice from people like Tom. As Nico mentioned, my colleague Steve Wolf can't make it. He had an illness in the family. I'm going to attempt to channel Steve to cover what he would have covered, but I am by no means an expert on what he was going to cover, and that will become apparent when we get to that point. So let me just start by talking about this measurement tool, the Health Opportunity and Equity Initiative. There are obviously many important equity measurement tools that already exist. We did not set out to create a new tool simply to add to the noise that in some cases exists. But we saw some needs for the field in terms of understanding contemporary structures and systems that create the inequities that we see. So in launching HOPE, we actually began this work in 2015. It was a very different political climate when we began the work. And as our politics have become increasingly polarized, we believe that now more than ever, we need HOPE and other related tools to shift the conversation to what is unifying, to where our interests align and how to make our country better. So we worked from a guiding framework where we focused on opportunities as opposed to disparities. So where possible with our indicators, our measures, we flipped problem-focused indicators on their heads. So we examined employment rather than unemployment, preschool enrollment and youth connectedness rather than things like high school dropout rates. And with increasing movement to shift social and health policy from federal to state governments, we center our measures on state-level comparisons among the social, economic, and environmental determinants of health, equity, and opportunity. So how does HOPE contribute to this landscape of data and measurement tools? We're clearly not the first or only national effort to create indicators on determinants of health and equity. As I mentioned earlier, we're very inspired by County Health Rankings and Roadmaps, Steve Wolf's Health of the State study, PolicyLink's Equity Atlas, which I hope my colleague Sarah will speak about because it's a marvelous and robust data tool, and the Opportunity Index among many others. What makes HOPE unique is that it focuses on where states and the nation can expand opportunities for all and tailor strategies for those most in need. We begin with an opportunity framework. So too often studies of inequity focus on the problem. To the best of our ability, we use a positive asset-oriented approach. As I mentioned earlier, measuring income, not poverty, tracking things like employment, not unemployment. And the goal is to reframe conversations to shift from disparities and problems to highlighting evidence that shows progress toward equity and where we can expand opportunities. We believe that opportunities for good health and well-being are a reflection of the policy choices that we make, and therefore emphasize that we have much to celebrate and we can always do better. So in using this frame of opportunity, we hope to be inspiring, but we also hope to offer a more common language that's more accessible for a broader range of audiences. So I think many of us have had the experience of talking to friends and family about this concept of equity and finding that we're stuck because they're thinking about it in a financial sense, not in the sense that we are, or in another sense. We also disaggregate data by race, ethnicity, income, and education. I heard the conversation about some of the challenges with grouping variables, and we try to go to the finest level of detail possible. In this case, it's the level of the state, because we're using survey data in many cases where we just don't have adequate sample sizes to create those grouping variables. We also, it's critically important, as a previous panel acknowledged, that we recognize the limitations of the 5 federal racial categories and 2 ethnic categories. there's considerable diversity within each of those categories. The example provided earlier about the Asian American Pacific Islander category, which is a completely heterogeneous population, we would mask, if we always use that category, we would mask the tremendous barriers faced by populations such as the Hmong, who face tremendous obstacles to health and well-being. So we acknowledge that the lack of more detailed racial and ethnic data may mask the needs and experiences of some of the most disadvantaged subpopulations, and where possible, we've highlighted these data limitations and provided notes of caution for data interpretation. We also set aspirational goals or benchmarks. I'm going to say more about that shortly because that's obviously most germane to this conversation. Once we have a benchmark or goal established, we then go further to calculate the distance to the goal for populations or for states to meet that benchmark. And that we can express either as a share of the population, a proportion, or an estimate of the number of people within a population group who would need to see their health or conditions for health improve to meet the benchmark. So HOPE metrics, we are measuring 5 different domains. One are health outcomes, and I'll show the specific indicators shortly. But we're also focused on a range of socioeconomic factors, aspects of the social and physical environment, and of course access to health care, offering these data both nationally and for all 50 states and the District of Columbia by race, ethnicity, income, and education. The specific indicators, these 28 you're all likely very familiar with. We draw them from many of the same data sources as other measurement tools that we've been discussing earlier here today, primarily American Community Survey, CDC's BRFIS and related surveys, and of course the difference is that we attempt to turn these measures in a positive direction. So we, for example, measure livable income. That's the share of households that makes over 250% of the federal poverty level. So we're measuring the share of households that have that livable income as opposed to the share of families in poverty. So I mentioned that benchmarking is central to our process. It's of course central to Healthy People 2020 and soon to be 2030. And so we believe that similar goals should be established for health equity, and that measurement of our progress toward meeting these goals ensures accountability and helps us know if we're on the right path. So these benchmarks provide that North Star to guide our progress in our efforts. Too often, however, in previous research on health equity and health disparities, the white population has been used as a reference group against which the health of populations of color are compared. This is obviously unfortunate, particularly because our nation is increasingly diverse with respect to race and ethnicity, and so we should therefore avoid implicitly or explicitly assuming that white is somehow normative. Also, in many cases, of course, whites are faring poorly, particularly those in rural communities, as recent research is finding. So moving out of using the white population as the normative or reference group is one of the most important aspects, I think, of our work. Rather, our benchmarks are based on how the best performing populations in the healthiest states are faring, not just on measures of health status, but on conditions for health as well. And so most often, this is the most highly educated or highest income group for the top 5 states for health opportunity. This is actually a strategy that we got from our colleagues at CDC, particularly Anna Pinman-Aguiar, who is also a member of our advisory committee. And so when this population is used as the reference group, that is either the population with the highest level of education or the highest income, we can set aspirational yet achievable benchmarks because there are populations that are actually doing this well. And this allows for comparisons of different populations within and across states, regions, and the nation. And we can also use the benchmarks to measure the degree of equity or inequity within a state. And this is important, as I'll show in an example, because in some cases states display a high degree of equality, but they can be far from the benchmark. Once the goals are set, we calculate the distance to the goal, which measures the progress that can be made to achieve the HOPE goal for any particular population group or state. And that distance is comprised of an estimate of the number of people who whose opportunities or health would need to improve to meet the goal, or the percent of the population whose opportunities would need to improve to meet the HOPE goal. We can offer these data both at the national level, but we're also able to offer regional observations and state profiles. So I'll provide an example of that, and I'll try to move through this fairly quickly with apologies because I want to leave enough time for Sarah. So here's a national level example of the percent of adults reporting excellent or very good health. Here we're obviously using CDC's BRFIS survey. Nationally, a little less than half of adults, about 49%, report having excellent or very good health. So we define this as having high health status. But when we look at the states that are faring best, those 5 states that typically end up at the top of most rankings, such as America's Health Rankings, be they New England states or Colorado, we looked at adults with college degrees or higher. 75% of those adults report having high health status. So we set 75% as our benchmark. Using that as our benchmark, we estimate that about 53 million adults would need to see their health status improve to be able to meet that benchmark. We're also able, of course, to disaggregate these data by race, ethnicity, and in this case, educational attainment, to see how far different population groups are from that benchmark of 75%. What we see here is what you typically see with epidemiologic research, that the higher the level of educational attainment, the better one's self-reported health status on average. But what's important to note here is that not every population reaps the same benefits from high educational attainment. In fact, there are many populations of color that don't see the same benefit from high educational attainment as the white population. So in this particular example, the closest population to the benchmark is the white college graduate population, with about 71% reporting high health status. So about 4% more would need to see their health improve to reach that benchmark. The Hispanic population, or the Latinx population, those with less than a high school degree, that population is furthest from the benchmark, with only about 17% reporting having excellent or very good health. Here's an example of how we can look at the degree of equity or inequity within and across states. So here we're looking at 4 states in the southeastern region of the U.S., Alabama, Mississippi, North Carolina, and Virginia. And in this example, overall, North Carolina is closest to the benchmark than the other 3 states. But as you can see, there's considerable inequity along lines of race and ethnicity, with some populations doing very well, actually approaching that benchmark, others being considerably far from the benchmark. Also in this example, Mississippi overall is doing the worst among these 4 southeastern states. But as you can see, there's less inequity across racial and ethnic groups. That's because every population is doing poorer in Mississippi relative to that benchmark. We can also offer state and regional comparisons. In this example, what we're displaying here are 5 of the health outcomes in our measures, beginning in the outer ring with adult health status. That's that high health status measure that I referenced earlier. Next to it in the inner ring is adult mental health, followed by premature mortality, infant mortality, and the innermost ring, which is low birth weight. And we've organized the states into 4 quartiles. Those states that are closest to the benchmark have the lightest color shading. Those that are furthest from the benchmark have the deepest color shading. And as you can see, just from a quick glance across the different regions, we find, again, what we would expect to see given other data, that the southeastern region of the country is faring poorer relative to the northeast or northwest on many of these measures. And we can also look specifically at a state example. Here we're using the example of New Jersey because that's where the home state of our funder for this work, the Robert Wood Johnson Foundation. Here you can see that New Jersey has a mixed picture of performance across our health status measures. They're number 22 on adult high health status, number 17 on mental health status, number 29 on premature mortality, number 9 on infant mortality, and number 6 in terms of low birth weight among all 50 states and the District of Columbia. But we can actually dig further into these indicators to look at both socioeconomic and racial ethnic variation on these measures. So again, using the example of adult high health status, what we see is that there are no populations in the state of New Jersey that come close to the HOPE benchmark of 75%. Whites are closest at about 58%, followed by the Asian American Pacific Islander population at 55%. Again, take that with a grain of salt, given the tremendous diversity within really all of these population groups. But we would need to see the share of African American, Latinx, American Indian, and multiracial populations with high health double to meet or exceed the HOPE benchmark of 75%. So in this case, what we're saying to the state is you have considerable inequity on this very important measure of adult health status. Here we are displaying where the state of New Jersey fares on all 28 of our measures. So we're seeing where New Jersey fares relative to the other 50 states in the District of Columbia. On some measures, New Jersey is doing very well. They're number 3, for example, on food security, which is simply the share of the population that does not live in a USDA-designated food desert. So again, our attempt to turn the measure in a positive direction, we're calling this food security. We can debate the concept of the term, but nonetheless, we think it presents an interesting way to look at the retail food environment in the state and its implications for policy. In contrast, New Jersey is not doing as well on things like housing quality, where it's number 43 among the states, or housing affordability, where it's number 44. So we're able to dive deeper into these indicators. On the case of food security, we noted that New Jersey was number 3 nationally. Here's an example of a success story. Almost every racial and ethnic population in the state is close to the benchmark of 97%. In fact, there's little variation across racial and ethnic populations on this measure. This is not to suggest that there aren't some communities in New Jersey that do face challenges in terms of having an adequate retail food environment for its residents. But as we began to talk to policymakers in the state and to try to ground truth this particular finding, we learned that there are a number of food initiatives in New Jersey, such as encouraging healthy food retail in bodegas and family stores, and not to attempt to draw a causal inference, but that lines up. It accords with our data. In contrast, on housing affordability, this measure is the share of households that are spending less than 30% of their monthly household income on housing costs, whether they're owners or renters. And as you can see, here's another measure where New Jersey is faring poorly. The benchmark here is 87%, but there's no racial or ethnic population that comes close to this measure. Again, the white and Asian Pacific Islander populations are relatively advantaged, but they still have a large share of the population that would need to improve to meet that benchmark. So we came up with a number of key findings from the research using our goals or benchmarks to estimate how far we have to go. And we found that if we had achieved our benchmarks in 2016, using our most recent data, 17,000 more babies would live to see their first birthday, 375,000 more adults would not die prematurely. As I mentioned earlier, 53 million more adults would be in excellent or very good health. And importantly to me, here's a figure that I find to be very striking, because from an equity perspective, it's at the root of many of the racial and ethnic health inequities that we see, and that is the poverty concentration of the neighborhood. So according to our data, we would need to see 70 million more people being able to live in low poverty neighborhoods, those with less than 20% of the residents being below the poverty line, in order to meet that benchmark. So here's where I'm going to channel Steve Wolf. Steve was going to talk about examples of population attributable risk, and I actually just gave you some examples of population attributable risk, where we're trying to estimate the proportion of cases that would be prevented if the risk factor were eliminated. And so Steve offered a number of really insightful estimates that many of you have seen. This is from the published literature. One study estimates that in 2000, 400,000 deaths due to tobacco would have been averted had we reduced tobacco consumption at that time. Same with diet. We would have reduced the number of excess deaths due to this factor by 300,000. Other examples, Sandra Galea and colleagues recently estimated deaths attributable to social factors. They estimated that in 2000, about 245,000 deaths were attributable to low educational attainment. They estimate that about 176,000 more deaths were attributable to racial segregation. I would challenge that, because segregation to me also determines where kids get to go to school. And the quality of schooling, educational inequities are also deeply connected to patterns of racial residential segregation. Here's some work from Steve and his colleagues that many of you may recall. They looked at excess deaths from 1991 to 2000, concluding that nearly 900,000 African-American excess deaths occurred in that time period. Had they had the same mortality rate of whites, those 900,000 excess deaths would have been averted. Other work that Steve also collaborated on with Dr. Satcher and others, this is the study many of you may recall where they estimated that between that in 2002 that about 83,000 excess deaths among African Americans occurred, the equivalent of 2 jetliners falling out of the sky per week. That was a line that caught the media's attention and was useful in helping to explain this population attributable risk to the general public. And a final example where Steve and his colleagues estimate the advantages of educational attainment relative to medical advances. And so they looked at the time period between, I believe, 91 and 2000, and estimated that there were nearly 180,000 deaths that could have been averted due to advancements in technology, but about 1.4 million deaths could have been averted had all people had the same mortality rate as those with the highest levels of educational attainment. So I've done my best to channel Steve, and I've gone over, so thank you. I look forward to the discussion.